ceded territory of the Coast Salish people, including the Musqueams, Squamish, and Tsleil-Waututh nations. At this time, if you could, if you're not coming from these areas, if you could recognize the territories on which you are working and playing in. Next slide, please. So just the agenda for today. I'm just going to do some quick housekeeping introductions. I'm going to breeze through the purpose and guiding principles and roles of a SME. I think our SMEs have seen this before. Then a bit of a CST overview, and then going over to the end-to-end clinic workflow, provider-focused workflow and demo break. And then as time permits, another part of the end-to-end workflow with the informal report, screening and triage, registration and scheduling. At the end, we'll have some time for questions as well. Just some housekeeping items. If you could have your first and last name displayed for proper follow-up. Also, if you could please mute your microphone when not speaking. And also, we'll be monitoring the chat. So if you have any non-urgent questions, we could address it there as well. And at the beginning, also to this session will be recorded, and this is for to help note-taking and for follow-ups as well. It won't be distributed on social media at all. Next slide, please. So in some introductions, I know I didn't see Catherine's name here. Sorry, I'm just gonna open this up here, my participant screen. And then we have our palliative clinical resource nurse, Alexandra Hogg, our palliative clinical resource nurse, long-term care, Joan Pham. Thank you for attending, Dr. Lois Addo, and our program clerk, Sabrina Sidhu. On the CST side, we have our manager, informatics, Hilda Chung, Sarah Newfield, who will also be presenting along with myself, and I'm also a clinical informatics specialist. Our registration VAs, Jocelyn and Danica. From our provider adoption team, Megan and Jessica. Our BA on the ambulatory side, Dolores Grizel. Our AA from ambulatory, Tyler Childs, our scheduling VA, Laura and Cynthia, and from our provider education team with Harmon Deep. Have I missed anybody? And if I have, if you could please maybe unmute yourself and say a quick hello. I'm just going to quickly look. Oh, there we go. Sorry, I'll just let people come in for a second. Hello, everybody. Sorry, go ahead.
It looks like so far everyone who's here is reflected on the slide.
Okay, perfect.
Oh, I don't see Catherine yet. But I guess we'll just I guess as Joan or Alex, are you guys able to kind of maybe send a quick message? Thank you.
Hilda, should we pause or should we just keep going with the introductory slides? I think Catherine has seen them quite a few times.
Yeah. Go ahead.
Okay, so next slide, please. So the purpose of this session, so it's a design session. So we're going to review and confirm Cerner build options that will be used to meet this clinic's identified requirements. After a review of the workflow, validate what works and identify any key gaps. And then also review the content that currently exists in Cerner, validate what content works as is, and identify any key gaps or changes required. There will also be some sessions afterwards in the preceding months, weeks and months. Actually, I think it's in January, the validation sessions. And then in addition to that, we'll also have scheduling specific sessions and order sets specific sessions as well. Next slide. Some guiding principles for change. Again, we have a few of them. Guiding principle number 1 is no change for the sake of change. This is when we would make changes to the our core content that we have. So if it has any safety, regulatory, financial, or content implications, we would make those changes to the system. Next slide, please. Our guiding principle number 2. Our enterprise focus is enterprise design, so we're configuring for an enterprise-wide, meaning all 3 health organizations. That includes PHC, PHSA, as well as VCH. We prioritize our design topics based on what is needed first in order to facilitate go live at each site chronologically. Then other design topics to follow a specific schedule, and these will be accomplished in alignment with a go live roadmap. Guiding principle number 3, our priority is must-haves. So while we're working towards creating a functional system, there will be opportunities in the future to customize it and fine-tune the system once we get everybody using the system. So we also divide it into must-haves. These are items that need to be completed prior to activation, and nice-to-haves, requests for changes or additional functionality that needs to be reviewed and evaluated post-activation. Of course, the role of a subject matter expert, we also call them SMEs. So these are people on the call from the site who contribute as experts and representatives of your areas to discuss both the workflows and the recommendations for future state workflow. You're also able to understand and think strategically about processes and workflows within your clinical setting. Also considering the requirements and the needs of all the stakeholder groups across all the HOs. You're also familiar with policies and documentation within VCH, and also confidently able to make informed decisions within your area of expertise. You could also collaborate with your clinical team to help inform the clinic design and communicate outcomes and impacts of the design with your clinical team. A bit of a CST overview. So again, we're the Clinical and Systems Transformation Project, commonly known as CST. And we're here to transform healthcare and processes to improve safety, quality, and consistency of patient care. Again, we've stated this is going to be rolled out over VCH, PHSA, and PHC over the next few years. Of course, our drivers, things that we think about when we're actually designing for the system, that we want to put patient safety first. We also want to improve the quality and consistency of patient care the best way every day. We're also improving the healthcare experience for patients and their teams. We're able to draw on data, gather better data to improve health systems planning, research, and proactive care. And of course, improve information system reliability and sustainability. Just a quick overview. I think we've all seen this before about where we are on the roadmap. A lot of these sites have gone live here. And here we are at Richmond Hospital, nearing the end of the activations. I believe GF Strong is one of the last sites to go live, as well as cycles of VGH as well. So in timeline here, we are, oh my gosh, we're nearing the end of November. We had just finished our UBC go live. I believe we're transferring to stabilization and sustainment. And we're projecting a go live somewhere around June here in 2024 for Richmond. And then I'll pass it off to you, Sarah.
Excellent. Thank you, Vince. So to start out, I know we're focusing more on the provider end today, but just for context for Dr. Addo and everyone else on the call, what I thought I would do is just open with a couple end-to-end workflows just to reflect the care you currently do and how that looks in Cerner once we get to go live. So I'll have two workflows. One will be an informal report workflow, talking about a phone call, a conversation in the office, or anything like that. And in this workflow, we'll also pretend that we have not gotten the extra clerk resources that we hope we have, just to show how the clinic would accommodate for that. So to start, Alex, Joan, Stephen, and others would receive their report from the clinician. They would do their screening and triage. It could be done on Cerner if the client has encountered a Cerner site post go live, but also could be done in Paris, Care Connect, and other platforms that you use. If the patient is accepted, then we go to scheduling. So the PCRN, as you guys have told us, will continue to be scheduled in SharePoint, so the home health nurse can access that calendar. The home health nurse is the one to notify the client of the date and time of the booked visit. From the clerk side, we are mimicking your current workflow. So since Sabrina is registering clients in PCIS, we reflect that here with the clerk registering the client into an encounter. And the type of encounter is called pre-home care. And since currently the PCRNs are booking into JNAP, we reflect that here, booking the provider and client together into Cerner. Next step is obviously the visit, and none of that changes. All the care that you give at the bedside remains the same. In terms of the workflow, sometimes during, but sometimes after the visit, we might see the provider initiate a referral, create a requisition, or write a prescription. And the chart will be updated to reflect any of those things. Staying the same for the PCRN as the current workflow documentation in Paris. And whether the provider creates these requisitions and charts on them at the home or after, ultimately they will also document on the topic of the visit and all the data they gathered. And finally, it seems counterintuitive, but we have check-in at the end. Just because the clerk is not with you at the bedside for the visit, we will have the clerk check in the client probably at the end of the day, but can also be the next day as well. And we will clarify how you can continue to document and give care, even if the client has not been checked in yet. When the clerk does check in, they change that encounter that they originally booked, the pre-home care encounter, to home care. And the typical workflow of this clinic, as you guys have told us, is in a consult basis, oftentimes just a one-time visit. So this kind of encounter does reflect that, and it will just auto discharge. Okay, so the second workflow that we captured is a faxed referral form. So a nice, tidy, filled out form. And let's say we got that clerk staffing that we're hoping for.
Yeah, sorry, just Alex did raise her hand.
Oh,
I
sorry,
think
Alex.
has a question.
Yeah. Let me pop
Sorry,
that.
just quick question about the second last step there.
Yes.
Provider documents in Cerner. I just
Yes.
want to confirm that provider documentation will make its way into Care Connect, right? It will
Yes.
be. Okay.
Yeah, I see Megan nodding her head. Megan is our expert, but yes, I do recall that as well.
Just making sure.
No, that's
Thank you.
great. Thanks, Alex. Okay, so the second workflow captures getting a nice tidy form filled out by our home health or long-term care clinician, and say we got our clerk support that we're hoping for in the building. So we receive that form and it's stored within an application called Work Queue Monitor. The clerk addresses this document that's in this Work Queue Monitor and creates an encounter just so they have somewhere to put this form. So then we continue with our regular screening and triage. And it's the same here. They do their review on Cerner, on Paris, and other places. And then we go to scheduling. So again, scheduling pretty similar. Home health nurse is notifying the client, PCRN scheduled into SharePoint. And here the encounter and scheduling are all done by the clerk. And then we proceed to the visit and the creation of referrals, requisitions, and prescriptions, documentation, and check-in and discharge. So really the major differences in this workflow sit in the beginning on whether we get an official referral form or we get a verbal report and who does the booking of the client as well. So I had a question for the team. So current state, if a referral form is faxed in, how does Sabrina or the clerk on duty notify the PCRN team that she received that at the desk?
Hello. So if I receive anything in the right fax, I'll send it to the PCR nurses by mail.
Okay.
Yeah, and if they're looking for something in particular, they just let me know as well that a fax might be coming in.
Okay, and by mail, do you mean you send them an email or
But
you
sorry, by email.
Okay.
To the group email. Sorry.
Perfect.
We're not
gonna pop
that,
it in
like,
Canada
ancient.
Post.
No, not Canada Post or FedEx or anything.
You can't be bothered.
No, sorry.
Excellent. No problem. So again, as the CST team, we just present you with your options. And interestingly enough, I didn't pop email in there, so that's okay. But options, pardon me, for that notification system could be, again, email as current state, a face-to-face conversation, a phone call or text. The PCRN also has the option to check in a platform called referral management. But again, we just want to make sure that you have your options and you choose what's best for you. And Hilda, do we need a decision necessarily in this meeting, or is that something the clinic can sit on for a bit?
Yeah, so that's really within the clinic, how you guys wanted to communicate in terms of these fax referrals in the future. So as Sarah has listed on here, in the future, you do have all these options. There's actually also another one. It's similar to an email, but it's within the Cerner system. It's called Message Center. So it's also similar that you can send like an email within Cerner. And that way you can actually attach the patient's chart and all the information within your email. So it's just a lot easier for the clinicians to even find that patient and to then go through with the triaging as well. Lois, I see that you have your hands up.
Yeah, I just wanted to double check. Maybe I'm just not familiar. Like, do we get referrals for our home visit program by fax, Alex, or is it mostly just referrals from nursing? Like, is this a
Mostly,
common workflow?
no, it's not.
Yeah,
It's
yeah.
mostly just from nursing.
Yeah.
Occasionally we'll get like BCCA PSM who's like, oh, we're discharging our client from our PSM. Can you basically have, because they're homebound, can you basically have palliative physician follow up in the community? But it's not a true referral because we still rely on our nurses to like eyes on, and there needs to be an actual need for consultation. So
Mhm.
yeah.
Um,
So
but
it's
like, would
not
it-
a normal.
Mhm.
Mhm.
Yeah, I think it might be fair to say we don't really get fax referrals for our home
Yeah.
visit program.
Okay, yeah,
Mhm.
yeah,
Mhm.
and this would also, like, I suppose what we're trying to capture in the future state is, yeah, that it exists as an e-fax in Cerner, but I suppose that form, so Joan, you showed me your request for services form. That one would typically come more by email than by fax? Yeah, she's nodding. Okay, okay, that's good to know. Thank you.
So it's it started with fax, but because it wasn't always showing up or there was a delay, we switched it to just exclusively email.
To email, okay, that's
Yeah.
good to know.
So
And I guess something,
Go ahead.
sorry. What I was going to say, somebody here said something about should we sort of nail down like a specific option? And what I was going to answer to that is it's just not going to work for this clinic. There are conversations, there's text messages, phone calls, texts from the doctors, like our palliative physician. So it's just, it will, I don't see that changing.
Yeah, no,
It's
I think,
informal.
yes, absolutely. I think for what we're trying to also figure out is the informal side actually stays the same. Like, we are not trying to change that. But in terms of what I'm hearing so far is that you guys don't get fax referrals. I think that's what we're trying to figure out. Do you get fax, or is it always going to be informal, like verbal, text, email, and things like that? So if there's no fax, then we can actually, what Sarah has presented earlier with the working monitor, then that function or that step is actually kind of mute in that sense, because you guys don't really use that step at all if there's no fax at all. So we just wanted to kind of confirm, should we keep that step? Because maybe sometimes that you might get faxes. I think that's what we're trying to figure out.
I think I personally, if anyone has any other opinions, let me know. I think that we just should not go forward with that. Because even when we do get the very rare fax communication, it has a separate channel. It ends up on our desk by magic. It is fine. And I wouldn't be sitting there setting up some kind of pathway through Cerner for this. Yeah.
Okay, because I did hear Sabrina did mention that she will get these right fax current
Yeah.
state. So in the future, the what we call the working monitor actually replaces your right fax. So if you do current state still get those right fax referrals, then I guess then we should keep the work queue. But if you're saying like, nope.
Well, the
it's
thing
not
is,
really,
the right fax is not specific to this clinic.
yeah.
It's like a home health fax number.
Yeah.
And because our home health program's not going on Cerner, that will still
That's right.
exist.
Yes.
So I feel like we don't really need to go that. Yeah.
Okay, so those right fax referrals actually is meant for home care, even though they kind of want you guys to be involved later. But then the home care nurse will do the first screening, and then they will reach out to you guys afterwards. Even if it does require you guys, it will still need the home care to do the initial step before you guys get notified.
Yeah, you could almost call it an FYI. Like, it just,
Okay.
I don't know. Some doctors request it, but at the end of the day, it's always going to be a question of, yeah, just a lot of things. So it's fine. We could just, I don't think that we need to go the extra step in Cerner.
Okay.
It's
so
not a
that's-
normal.
Okay. I guess I kind of asked all my questions. Not sure anybody from the CST team has any additional questions about the vaccine side, because from what I've heard that you guys don't receive these fax referral, so we don't even need to kind of go through the work queue. If that's the case, we'll just kind of use the informal, what we call Cerner term, informal referrals, which is just like verbal, phone call, text message, email. So those are all considered as informal referrals.
Yeah.
Pardon me, it's
Dolores.
Dolores from the CST team. I was wondering, do you ever receive faxes for anything else, you know, besides referrals or other things for the clinic? I'm just trying to make sure that we like have covered that so that we're not, you know, come go live, you're like, oh yeah, we also receive, you know, documents for this for the patient or something. Like, does the patient ever send in, say, like documents via fax, or, you know, does like say like a pharmacy send anything via fax, or like it just, you know, I'm just kind of thinking of different situations, but we just want to make sure we've covered our basis, we're not missing anything. Like faxes from the pharmacy as well. So that's one thing that we do get to the right fax. Okay. So faxes from pharmacy. Okay.
I'm just
And would you ever index that, I guess, to the patient's chart? You would, right? Or would you, like, in your current state, how do you deal with the faxes from the pharmacy? So if any faxes that we receive from the I always keep a copy in the patient's chart. Okay. Okay. So that might be something for our design team to think about. Yeah, we can think about it and talk about it internally, but we might need to keep their work queue monitor simply for that purpose then. Thanks.
Alex, you have your hands up.
I just want to clarify. So in this particular meeting, we're only talking about home visits, not PSM, right? So my concern with the piece about pharmacy faxes and stuff like that is, like, right now, if Sabrina's not here, someone would have to cover for her. Sometimes if it's not going to be Megan or someone who has Cerner, those faxes would go missed. They already come into the established right fax, and we have another like program assistant team for home health as well that have access to those. So I'm just curious, like I wonder if it would be, let me know what you think, Sabrina. Like I'm worried about having something like that just route through Cerner when it's the purpose, like from my perspective, the purpose of this situation with Cerner is strictly a place in which to schedule our home visits. And there are some clinical applications, but because of the way that we work with home health and what they will have access to, I just worry about stuff getting missed or having less opportunity to catch it if we.
No, you're right, Alex, for that. That's actually a good point as well.
So I was hoping Catherine will be here to actually maybe talk about this. I know that there is kind of like plan to have extra clerks for the check building to do extra coverage. So I don't know where that is at, because that's more site operations decision in terms of that. And Alex, you bring out a really good point in terms of the faxing. So Dolores from our ambulatory team earlier did ask, that's one of the reasons why she was asking. It was like, do you, other than referrals, do you get any other faxes, right? Like, so it sounds like you guys do get prescriptions and other stuff that currently you do attach to the paper chart. So with that said, I think the decision from Catherine from PSM per se is that each of the clinics in the Cerner term will get a fax number, which then will be linked to what we call the work queue monitor, which is our e-fax kind of application that stores all your faxes. So when you do get a fax number attached to your clinic, when the fax comes in, it goes right to your clinic queue. So then that way, even if Sabrina is not there that day or off sick, another clerk can still go into your queue and still access that fax and attach it to the patient's chart. I guess the question is, like, how urgently as soon as the fax comes in, you need it to be right away added to the patient's chart, or can it be wait until like when there's a clerk available? Another option is that knowing that right now, Catherine has requested for all your nurses within your clinic to have what we call registration and scheduling capability. So my understanding is that you guys will be also have the ability to attach the fax to the patient's chart, because you do have registration and scheduling capability. I just want to confirm, because I do have the CS team here. For nurse with record sketch, they will have work queue access, right? I just don't want it to be speaking out of turn here.
We have to request it. So just
Okay.
on the monitor ticket, we can request that position have access to that queue.
Okay, perfect. Thank you, Cynthia, for the confirmation. So, so if it is a huge concern, because of resources within your clinic, and you do wanted to make sure that those documents do get uploaded onto the patient's chart at a timely manner, we can give all the nurses the ability to kind of do that when there's no clerk coverage. Does it help?
So I hear what you're saying. My counterpoint, I really think, so I tried to call Catherine. I'm not sure where she is, unfortunately, but I do think we should maybe revisit this with Catherine.
Yes.
Firstly, for like an actual decision on it. But my real 2 cents on this, to put it very simply, is that these patients, so our team is a consultative team. Our nurses who are going to have access to Cerner are actually not on the home health team. These patients are home health patients. So it's just a weird way that we've broken everything up. But these patients are actually on that team. And so by doing this, we take away the ability of the clerks and the other team members working with the patient to collect this information about them. And even though we have access, it's only me, Stephen, Preeti, Joan, and who am I missing? I think that's it. Oh, and maybe Jen sometimes. And we have 300 palliative patients. So I just don't I already run around every day. I just don't see if we didn't have coverage, it's not really an ask that I want to move forward, that the nurses start doing admin stuff, because it's just too much. I do think it's not my place to choose, but that's just my 2 cents on it. Honestly, I think it's just a difficult situation because of the way the team is split. We are not in home health, but these are not our patients. Technically, they're home health patients. We provide consultative services, including palliative home visits. So it's kind of a weird setup. I'm sorry. But yeah, maybe we should wait for Catherine. I don't know if maybe she's called in sick today and we're just not aware. Joan, were you able to contact her? No. Yeah. Her phone
No,
goes
and I see that she was on holiday until
yesterday.
She was supposed to be back today.
Yeah. So
Yeah.
sorry.
No, that's okay. Let's just maybe put that on hold for now. I think I agree. I was hoping Catherine would be here to also make that decision as well. So since she's not here, let's just move on with what we know so far, and then just put that work queue to hopefully maybe we'll have another session tomorrow. So maybe we can ask her then as well.
Sorry, I think the functionality is super cool. It will just make things, more difficult to access for everybody.
No, thank you, Alex. And we definitely don't take it personally. It's really important to have your insight and the reality of your current work and your workflow. So no, it's super important. Thank you. Okay. Well, we might be revisiting this workflow in terms of not getting fax referrals, so no problems there. Great. So I will pass it over to Megan. She is responsible for doing a demo for our lovely Dr. Lewis for the provider workflow. So Megan, if you're ready to roll, just make sure you got it there. Maybe I'll stop my share.
Yeah, thank you so much. Hi, everyone. My name is Megan Fiquette. I'm on the provider adoption team with CST Cerner. Just want to introduce myself for those of you I haven't met yet. I'm an RN by background. I have been on the team for the last 2.5 years, and just took Palliative over from my colleague Jessica, who you might have met. So I'm excited to work with you guys going forward. Let me just share my screen here. 1 second. All right, and just while I'm presenting, I cannot see if someone's raising their hand. So if my colleagues would just let me know if anyone has any questions as we go along, that would be great. Thank
problem,
you.
Megan, I'm on that.
Appreciate it. Okay, so we are going to go over, you know, sort of a shortened version of our outpatient sort of, you know, clinic visit, more in the context of how you would go about reviewing the chart in the context of a home visit. Again, I know that Dr. Addo, you've received a few demos about the different functionalities in CST Cerner, so I will certainly keep it brief, but please do let me know if you or if anyone has any specific questions. So when we are starting the outpatient visit work, typically the tool that we use is ambulatory organizers. So I'm just going to click on that, and that will show us sort of how we're scheduled. It's also based on a resource. So I'm just going to select here on resource selected, and I'm going to see I can search for an individual provider's name, or as well as a group of physicians or clinicians, for example, here. So I'm going to look at Dr. Addo's schedule today. And here I can see that there are 3 patients that are scheduled in ambulatory organizer. Left to right, you have the time, duration, name of the patient, details of the visit, their status, and then also a note section, which includes the reason for visit. So this information is typically entered by whoever's accepting the referral order, or however that stuff is sort of processed, or whoever is booking the appointment into the schedule here. So for the purpose of today, I am going to use this patient here, Anna. So if I hover over her name before clicking it, I can also get a little bit of just quick information, including the referring physician or any like phone numbers and things like that as well. I'm going to click on her name, and it's going to ask me who I am and why I'm entering into the chart at this point. If it was actually scheduled to me as this particular physician, this would not pop up because it's assumed that you already have a relationship with this person at that time. But for now, I'll just say that I am the consulting provider. Oh, I'm just going to go back. I just forgot one step here. As we're beginning the visit, one thing I wanted to highlight is it's important for the physician to come in and change the status when they're arriving to see the patient, or again, shortly after they have seen the patient. When I click on the word confirmed, you'll notice there's a bunch of statuses here, and the one that the physicians will use is arrived. So I'm going to click on arrived here, and then that will just turn this color white. And that essentially would tell Cerner electronically that, yes, I'm actually physically here seeing the patient. We also use this in the context of like a virtual visit, for example, and that also just indicates that the patient is actually there and confirm that you're seeing them. Yes, Lois.
I just wanted to check, you said it's important to do it like at the time or shortly after. Like what will happen if we don't do it? Because we don't all carry laptops with us when we're out on home visits. I'm not sure if that will change once we're on CST, but often we'll do our documentation, all our charting after, and that might be at the end of the day.
Yeah, that could totally be fine. I would just recommend kind of coming in and just changing all the statuses. It doesn't have to be right in the moment, because what will happen after you arrive the patients, then the clerks will be able to check them in that status. So it's just one step that you would have to do at some point in your workflow of your day. It won't affect any of the orders that you create or anything like that. It's just one of the steps that needs to be done.
And then does it have to be us that does it? Like say, like if there's like a clerk, or like can someone else do it while we're out during the day, or is it only physicians that can arrive the patient?
I will default to the rest of my team for that question. Typically, again, we often see the physicians doing the arrive status, but I don't know that there's, I guess that's really just an indication, like, would there be any other time where you're interacting with a clerk to say, yeah, we saw everybody that was scheduled for today?
Yeah, I mean, I think we could like easily send a quick text back, like patient seen.
Yeah,
and then we don't
because in that
yeah.
situation, and again, I'll default to the rest of my team as well, but if it's just as easy as that, saying, yeah, we saw everybody, we're all good. Do the physicians need to arrive the patient, or could the clerks or somebody else just check the patient in?
I don't see why it has to be physician to do it.
Yeah.
So I think we just showing you the functionality of what is available in Cerner. So as long as there's communication, I think that's what we wanted to really make sure, because these home visits are done outside of the clinic, so it's very hard for the clerk to know whether the visit actually happened, right? So, so as long as there's communication, verbal, text, email, or using a RIE function here, clerk can see, and then they will just then forward to the patient. And any of those communication is fine with us.
Yeah. Unfortunately, the physician does not have the ability to check in a patient within their workflow. So that is just like the step that we're looking for eventually. Someone's got to check in the patient. So again, if that happens, just informal communication, and then someone behind the scenes can go ahead and do that for you. Absolutely happy to do for you guys to do that as well. Okay, so to open up the patient's chart, I'm just going to click on their name here. And again, we'll just head over back to the chart here. So again, depending on how you conduct your work, you may or may not be reviewing parts of the chart prior to seeing the patient. Sorry, Lois, do you have your hand raised again?
No, sorry, I forgot to lower it.
No worries, just double checking, thanks. Okay, so you may be reviewing different pieces of the chart. For example, their advanced care planning, goals of care, you know, perhaps whether or not their applications have been faxed, so on and so forth. You may be coming into the document section to view other documentation from the chart as well. For example, maybe an old home visit note. I just put something in here just for fun to have something to click on. You may want to be reviewing their labs, diagnostics. If they've had vital signs documented, they will also flow into the chart here. Also looking into their home medications. So here we can see that potentially this patient may be having some constipation issues by what they have documented here. I would also probably go in and complete my meds history potentially. Also leveraging our external integration into PharmaNet as well through this button here. I'm just going to hit document history. We'll just say that there were no changes for today. As we're getting down to our documentation, again, I know that you've seen a lot of this, Dr. Addo. So, you know, you may be documenting some of this depending on if you get a laptop, depending on what you have. I know a lot of this will kind of still be in flux. So what I did want to highlight was Jessica did give me handover as well about the auto text that you guys had created for some of your inpatient work. So I would very much like to work with you on an auto text document potentially and just learn a little bit more about how you would document potentially in this setting. Probably another date outside of this session, but and then we can maybe look forward to doing some specific documentation for the clinic, for the home visit workflow that might work for you a little bit better. So in our history of present illness section, I'm just going to type in something just so that we can have that flow through into our note. Again, any of these narrative boxes you can type in, you can click in here and also use your dictation if that's also how you document. In physical exam, again, same, you can use an auto text, dictate, or type in. Some physicians also like to use an auto text in their physical exam section. So they might do something like, you know, their sort of normal blurb of their physical exam or whatever they might be doing. So I'm just going to type in here blurb for exam. And then next is our active issue section. So again, here we can see that another physician through another interaction with the Cerner system has documented some chronic issues for our patient. So again, here just wanted to highlight that these are great ways that other physicians or other people interacting with the system can see what they may or may not be, you know, working with right now. If I was going to want to document on one of these particular issues, so let's say this visit was related to constipation, I could also select the button for this visit. And in the physician documentation section, that will also give me a nice little box to be able to document on about that specific issue, if that's so how I chose. So the next section that I do want to highlight as well is just a little bit about placing orders. Again, I know that this is kind of a repeat for the different demos that you have seen, but I'm just going to head over to the Outpatient Quick Orders tab. So let's say for this particular patient that we were going to go ahead and order an ultrasound for them. Perhaps they're having some issues with constipation. Let's say we want to order an abdominal ultrasound, and perhaps we're going to go ahead and order some long-acting hydromorphone for that patient as well. I'm going to come down here and just find my prescription. After I click on those two orders, they're going to highlight green. And then I'm going to come over to my orders for signature box or my Amazon shopping cart here that is loaded up with my two orders. From there, I'm going to click modify my details, and then I'm going to take a look at some details that need to be modified. I always look for my angry blue circle, which tells me that something is missing from that order. So in my hydromorphone order, let's say I just wanted to leave it as is. It's asking me to route it to send somewhere. In this situation, I am just going to say, do not send handwritten controlled prescription. So for anything that you are writing a prescription for as well, that's controlled, you could select this option. Otherwise, you could just say, do not send other reason. And again, that will just populate it in the chart as a prescription, essentially. So for today, I'm going to say, do not send, because I'm going to write that in my prescriptions. And then I'm going to head down to my ultrasound abdomen. And so for here, I'm just looking for my yellow field. So I'm just going to say, this is the reason for exam. Of course, we would just fill out some more clinical details. And then also I'm going to come down to the scheduling location section here. And I am going to be looking to schedule this to one of the medical imaging sites. So just for my clarification, would you often send patients directly to Richmond? Is that most often where people would be having imaging done?
Yes, that's correct.
Perfect.
Yeah.
Great. So in that case, for X-ray, ultrasound, so on and so forth, I would just select Richmond. And again, you can fill any other details that you might need. And then I'm going to go ahead and click sign for both of those orders. And if I want to take a look at my handiwork, I can just come over here to my orders profile on the right-hand side. Just going to refresh my chart, and there I can see the 2 orders that I've placed there. All right, the last one that I just want to quickly highlight is a referral. So let's say that this patient is going to be sent to the Richmond Pain and Symptom Management Clinic. So let's just see how that also works. I know that is something that some people on this team have been working on. So I would just come down to the referral order and click on it. When I do that, I'm going to get that referral reference text pop up that tells me all about, who to send, who not to send, all the additional information, so on and so forth. And then again, here is your reference auto text for your referrals, and then also rename with a note, so on and so forth. So if I was a physician who didn't work in your area, of course, I would copy this auto text. I would open up a new note. I would go ahead and include that information. For now, I'm just going to go ahead and click OK. I'm going to go up to my orders for signature box and modify my details and just continue to fill out the information for the referral. So let's say I want it to be next available. Location, I will just select here, and then I will just fill out the details. This is the reason for the referral, and I would just go ahead and click sign. Okay, so just a couple last things just to highlight documentation wise. Just going to come back over to my outpatient chart tab. And always our note hyperlinks are down here at the bottom. I'm just going to fill out one more box here. Say this is the plan. All right, and then down at the very bottom here, also just wanted to highlight that Care Connect is also integrated within our patient's chart. So both here, you can also find it over here on the left-hand side. When you launch Care Connect from internally with Cerner, it will open up directly into the context of the patient's information on Care Connect right here on the screen. There's no other browser that will open or section that you'll have to log into. So it's just nice to be able to see everything directly from there. Okay, so the very last thing would be, again, executing or generating some of our documentation. So we're going to launch a palliative clinic note free text here. And I'm just going to highlight a little auto text document template that I just sort of modified from, I believe, what is the inpatient consult one. But let's just pop it in here. So I'm just going to do .pal care home visit. We'll just hit enter. And then this will generate, again, a different kind of note type for us. So I had the pleasure of seeing, I'm just going to select here, finish this note out. She was seen on. Any brackets or underscores here would mean that you could say next field for your documentation. It just pulls in different information from the chart, including their past medical history, anything I typed into that box for history of present illness. Because we did the home medication history, this is also pulled into the note, as well as her allergies. And then again here, just some different documentation just to fill out as well, depending on what's happening with the visit. From there, I'm going to go ahead and click on sign and submit. And then always really encouraged to change the title for the visit. So this might be something related to the home visit. I'm just going to type in home visit for today. If there was somebody that you wanted to CC on this note, you could also do that. Based on this being a clinic note, it will automatically distribute to the referring physician and the PCP, and that is all through Care Connect. So it will be distributed to Care Connect that way. So just wanted to highlight as well that you don't have to add those people on. It does get, the clinic notes do get automatically distributed out to them, and then others can find it on Care Connect as well. Lastly, I'm just going to hit sign to sign off this note here. All right, and then I should be able to find that in my little notes documentation section. So here we have that note that I just generated here. All right, that's just a fast and furious home visit demo. Any questions? Great.
Oh yeah. I had one quick one.
Sure.
So when we generate the prescription, will that go straight to the pharmacy?
So not yet. So by the time we do get to Richmond, we will have eFax prescribing within our system. So that will be coming. It will look very similar. So we really are encouraging physicians at this point as well, just while we do training and things like that, or while we're exposing people to what it looks like to write a prescription, because that still will be needed to be sent off to the pharmacy as well. But yes, we will have an integrated eFax prescription writing.
Okay. Okay, so we generate, like, if that system is not in place yet, then we would generate the prescription, and if it was an opioid, would it print back at the CHAC then? And then it would then have to be faxed to the pharmacy? Or do we just write our prescriptions?
Like right now, for example, if you guys went live, you would just be handwriting. Yeah.
Gotcha. Okay. Okay. And then for the imaging, is it just the hospitals on Cerner that we can send imaging recs to? Like sometimes we'll send chest x-rays to like some of the local Richmond places. Will that be available as well? Okay.
Yeah, absolutely. I'll just go into this order just to show you quickly again. You are welcome to directly order to any of the sites that are on this list, directly to their medical imaging queues. Again, for any of our CST Cerner sites, so BC Cancer, BC Children, so on and so forth. If it wasn't on this list, at the very end, there is a print to paper option. And what that does is it will generate a requisition that can be taken to any outpatient sort of imaging department for that patient to go to.
Okay.
Great. Okay. I will hand it back over to Sarah.
Wonderful. Thank you, Megan. And Cynthia, are you ready to just do a quick demo of client check-in, or at least cover check-in and the encounter change for Anna?
Sure. Yes. Absolutely. For that patient, Anna.
That's correct. Yeah, the one that Megan just demoed.
Share my screen. 1 second. Okay, and let me know when you're seeing it. And you know what, Megan, I am so sorry. You sent a referral in for our patient Anna, did you not? So sorry, Sarah. I can just check in one of these appointments, right? Because the referral hasn't been. We kind of skipped. Like she placed a referral, but we haven't like actually gone through all that process yet. So
no problem.
As far as checking in a patient, you were in Power Chart. Sorry, what day were you on, Megan?
Today.
You were on today?
Yeah, Anna should be booked in for an afternoon visit, but maybe it's not populating there.
Okay, it's this one right here at 1:30, right? Yes, I found it. I'm so sorry. Okay, so, and we were kind of just talking about the communication. You don't have to click the arrive button. You know, as you said, you might not have your laptop with you, and a clerk does not have to go into Power Chart and click and change that to arrive. If you're communicating with the clerk in some other fashion, such as, I don't know, a note or stopping by the office, whatever it is, a call, a text, an email, whatever communication, they can just go straight from appointment book, and then they can go ahead and check in that appointment. So I'm going to go ahead and do that. And just by, sorry, we have the encounter is in a pre-admit status. I'm going to click OK. That is going to force this box over here, and I'm going to click the register outpatient. Again, this is all the clerical function of check-in, and that will take me into a registration screen. I'm just going to kind of format it here just so you can see that it's a pop-up box with a couple of fields that I have to fill in. This patient, it's been here before, so we have a lot of the information already. So really, we just need to fill in a couple of the encounter fields, and then, take their information in and complete. Let me see. I know I always get caught with at least one. Okay, is it no? Great. I should be able to finish that. I'm not going to print any documents, but if the clerk needs to, labels, face sheets, armbands, whatnot, that can be done. So it can be labeled and sent out. And then the appointment turns from a blue color to a green color. And if we hover over it, it says checked in. So that is the end of the check-in for the clerk. And if I went back into PowerChart, into ambulatory organizer, and I'm sorry, go ahead. Does somebody have a question? I'm going to just not that you guys are living in here, but if there is anyone living in here, if I refresh for Palliative, then I should see that 1:30 appointment is now in a checked-in status. And that's it. Any questions on that process? Okay. Back to you, Sarah.
Brilliant, thank you. All right. Let me just get my sharing going again. And as Megan talked about, and we did mention briefly in the chat, even if the client is not checked in yet, because obviously the clerk is not at the visit, documentation can still take place. I know the providers may not have a laptop, but if they did, they could do anything they wanted to in Cerner in terms of capturing orders, referrals, or requisitions, and document, and that can be saved to the permanent chart without a check-in being done yet. And as we discussed, there will be an auto discharge function so that this doesn't have to be manually done. And follow-up orders can be created. I know this isn't typical for your clinic and you function more in an expert consult, but should a provider prefer to schedule a follow-up, the recommendation from our team is that a new encounter is made for that next appointment. And we did cover this briefly, the provider changing an appointment to arrived or your existing workflow of communication between providers and clerks. Okay, well, we're just getting close to the end here. What do you guys think, Hilda? Should we do a 5-minute stretch break just to let people move, since we might be having less content overall without work monitor?
I don't know, because we don't really have much time.
No problem. Yeah.
And then I think Alex also needed to go at 3 minutes. Yeah. In 3 minutes. I don't know.
Basically don't have her anymore. Yeah. Don't worry, Alex.
Yeah, and then I guess for the next little while, for the remaining 30 minutes that we have, so we will still have Joan and Sabrina around.
Yeah.
Maybe
make the most of our time instead.
Yes, and then also I guess can you see what kind of content are you gonna go through afterwards?
Yeah, so we'll hop to the demo from myself and Cynthia for clerk and PCRN duties.
Okay, and then I guess Joan, are you okay to be kind of speaking to this without Alex?
I'm gonna do my best. I feel like it's still quite an abstract concept. I'm like, okay, this is what it's gonna look like. So yeah, I'll do my best to chime in.
Okay, sounds good. Okay, so we can just maybe continue.
Excellent, sounds good. Okay, so just briefly, this is the workflow that we'll be demoing now from myself and Cynthia. So I'll be functioning as a PCRN and Cynthia as a clerk. So just briefly again, the PCRN gets their report, does their screening and triage, off Cerner and on Cerner as necessary. If the client is accepted, they're scheduled and into SharePoint, and the patient and the provider are booked into Cerner. So we'll pretty much capture just this initial stage since Megan covered home visit onwards, which is more the provider stage. Okay. So let me just get to where I need to be. Sorry. Okay. And can people see my screen for the power chart application? Yeah, excellent. Okay. Okay, so in this scenario, let's say the home health nurse in my office has told me about a client that they want ideally to be seen by the palliative provider, and I need to do my research to determine whether they're appropriate or not. So of course, if we're doing chart review on Paris or Care Connect, that's not something that we'll demo for you. But if we're live for Cerner and this client has been seen on inpatient or at PSM or anything like that, then I can have a peek into the chart that way and see what I can find. So I have Mr. Francis here with us. So what I will do is go into the search function in the upper right corner, and I'll just search him by his last name to start. And I might be chasing windows here. There we go. So obviously, if you have a Chan, a Chung, a Sidhu, you're going to have lots of different patients, but it's just kind of a starting point. And then there's extra fields we can fill out, such as the MRN and the PCRN. But I know that for Francis, this is my guy here, so he's my only one. And what I'm going to do is just select an encounter that he has, just to have a look at his chart. So what I have up at the top is called my matter bar. I've got his name, his allergies, birth date, gender, different encounter, and if there's any isolation or any other flags that people have assigned, maybe a violence risk precaution, we could see that here as well. So say I want to know a little bit more about Mr. Francis. One area I might go to is documentation. So I can see here there's a palliative medicine note generated by a physician. So I'll just pop that open and see, okay, he was seen for breathlessness and he has a history of stage 3 liver cancer. Might see some vitals. Lab work could also populate here if it's recent enough. A surgical history, a brief med list and allergies, just to get to know him and get his clinical picture as well. I might also pop down to vital signs and measurements. I could see, oh, he had a little bit of a higher blood pressure, higher respiratory rate that tracks with his complaint of breathlessness. So there's lots of different areas where we might be able to find some more information in Cerner. So say after everything I've found, I say, yes, he is appropriate for our clinic and for physician home visiting. Since we're going to mimic the current workflow of the clerk doing a registration piece, this would be the time where I would tell the clerk, which for today is Cynthia, to create an encounter, essentially register this patient for this particular visit. Now, out of interest, briefly, Joan, what I will show you is also an option, if it cooperates, and again, I might chase a window here, to create an encounter by myself. So there's Mr. Francis here, and you'll note there is a button here to add an encounter. So say there's no clerk for the day, Sabrina is in a long conference call or assisting a client who's having challenges at the front desk, and you're like, I really need to book this so that it doesn't get forgotten or for whatever reason. The functionality does exist. And I know we are not hoping to assign clerk duties to nurses. We're trying to avoid that as much as possible. But just briefly, just wanted to show that if you really wanted to book and you didn't want any barriers, the functionality does exist there. So alternatively, let's say I'm happy with my chart review, he is eligible and we want to book him. The next step would be the current workflow you have of just notifying the clerk, okay, I'm ready for you to register the patient. So in which case it would be a verbal in this scenario. So I'll say, Cynthia, I'm ready for you to register this client so that I can book them.
Okay.
And let me just stop my share.
I think I might have stole it from you.
Oh, perfect.
Okay, so as the clerk and you need an encounter in order to move forward. So again, I'm in the same chat book that Sarah was just showing you. So I click the person little head here, and I'm going to go ahead and add that. I'm so sorry. I think it was at the same 7400. What was our
32619.
32619.
Yeah.
Did I get too many zeros? Okay. And I'm going to add encounter. And this is the same exact palliative, same exact steps that if you needed an encounter and did not want to, again, walk or call or do whatever it is, you could just do these steps. Pre-register outpatient, click OK. Box pops up. And this is the registration screen. Again, sorry, let me just kind of format it for our viewing here. The patient's been here before. There are really 4 fields that I need to fill in. The encounter type is pre-home care. The medical service will automatically, I'm going to fill it in today, but that will be something that will automatically populate. And then I'm going to, I think I hit complete. Sorry, it's going to catch me right here. Estimated, I can put T for today, in for now, unless I actually know the date and time that this patient's coming in. I'm going to go ahead and complete. And that gives me an encounter number. So I'm going to click OK, and I'm going to turn it over to Sarah. I'm going to communicate back to my nurse that I have created the encounter. Oops.
Hey, and you guys can see my Sketchup book here. Perfect. Okay, so scheduling appointment book, you'll hear us call it Sketch App Book. This is the application within Cerner Suite to book appointments. So let's say that I want Francis to be booked on Monday, December 4th. So I will go within my little book here, which is my palliative home visiting book, and hop over to appointment. So based on the filters we've assigned, our Richmond Health Services Palliative Home Visit Clinic is already the appointment location. Now, of course, the client is not seen within the clinic, within check, but it's kind of the virtual location that's assigned to this book. So in terms of appointment type, see if I'm happy with it here. So I will do palliative follow-up just because I know Francis has been seen by the palliative team before. So just to avoid any blocks there in scheduling, I'm going to say it's a follow-up. And I'll type his name here. Francis. And I'll click those 3 dots there just to make sure I get the right encounter for this booking. And again, just drag it over. Okay, so I see he had previously an outpatient encounter with the Pain and Symptom Management Clinic. I know this one's out of date because I have a discharge date over there. Now, what I might do is actually refresh my page because I might not have the right one right now. And let's start again.
No, that should have, I think if that's the encounter, if that's the
okay.
If that is the medical record you gave me, I should have created an encounter.
Yeah, I just see a pre-home care that is has a discharge date.
Right, and I think that's from our earlier. So
yeah, our little practice.
Sorry, I've done something.
No, that's okay.
And I put in the right. I thought I put in. Let me go look.
Sure.
Did I not?
Sorry, let me create it. Oh, I think you may have created it under the Anna patient.
Oh, I can look right.
How did I do that? It's so funny because I put in the medical record number. I must have been 1 digit off. Maybe I put an 8 instead of a 9 or something. I'm not sure.
Oh yeah. Here, Anna has a pre-home care. Yeah, that's okay. Yeah, 205. That's the one. So again, let's make it clear. Anna has a pre-home care encounter that has not been discharged yet. So I know that one is active. And it was made just a few minutes ago, so I know that's the right one. So I'm going to double click that one. Let it think about it here for a sec. Okay, perfect. So reason for visit, I'll keep it super vague, symptom management. And in terms of priority, I know for the PSM clinic, we talked about within 1 week selection. So I'll do the same for here. And for the referring provider, I'll just put our Dr. Test, who is very busy with every patient within Cerner. And we'll say Anna does not need an interpreter. Visit modality means how is this visit taking place? So whether that's in the long-term care site or in a home visit, the appropriate one is in-person offsite. And we won't be proceeding with appointment reminders per your request, so we'll leave that alone. And there we go. So every field that had a yellow background and a red star has now been filled. So now I can select move. If I didn't fill it incorrectly, I wouldn't be able to do that. So I'll click move. And now I see Anna's name over here. She's ready to be scheduled. So let's find the day we want. I said December 4th. And I'll click schedule. So it pre-populates with some options for how I could book this client. And I see that I could do 9:30, I could do 11, or I could do 1:30. Let's say Anna likes to sleep in a little bit, get some extra rest. So I'll click 11 o'clock and book her to Dr. Addo. So here she pops up in this nice yellow box right here under Dr. Addo on the 4th of December. The box is yellow because it's still pending. So the last thing I need to do is click confirm up on the right-hand side here. And again, I'll just bring my confirmation here. And it looks a little bare right now just because Anna's not a real person. But some clinics use this confirmation page to send it out to their clients for preparation before their clinic. But either way, if we're not going to do anything with it, we'll just press OK. We won't print it. So once I hit confirm, now my child turns blue and the appointment's ready to go. Let me get back to our slides here. So I did cover this briefly. But the encounter type, just for your interest, for Sabrina and for Joan as well, we're talking about a pre-home care and a home care encounter type. Basically, it signifies the type of care, the modality of care that this client is receiving. And like we mentioned, even if the client's not checked in, provider can still document and place orders while that is still waiting to be done. In terms of the medical service, of course, we're going to proceed with palliative medicine. And this does have implications for statistics and planning, and also supports things like reports for sorting by the medical service that clients are receiving. So this is something that we might have to revisit once we have more people present. But there was a decision made by the PSM clinic regarding label printing. So at registration, PSM clinic requested that an armband, a face sheet, and 3 patient form labels are available to be printed, but not automatically printed. So you'll notice that there's a checkbox that says do not print documents, and that is the standard pop-up that happens, is it doesn't mandatorily happen. In terms of a print label conversation, this is for our bedside clinicians. The PSM clinic requested for 10 referral demographic labels and 3 patient labels to be affixed to a paper form. So Hilda, if I am correct, we'll probably wait on a conversation about this maybe till tomorrow.
Sorry, can you repeat your question again?
Yeah, no problem. I'm guessing that we might wait until tomorrow to have another conversation around label printing and the selections that the clinic wants.
I guess
Maybe.
it's up to Joan.
Yeah.
Do you feel like this is something you and Sabrina can make a decision, or do you want us to wait until? Okay, sure, sounds good.
I think it's definitely better to wait just to make sure.
Yeah, sounds great. Okay.
Actually, I do have a question.
Of course.
Sabrina, do you currently print any labels or face sheets?
So I do print face sheets for all paper charts and 10 demographic labels just to start the chart off, and then just give them accordingly then afterwards.
Okay, good to know. Well, we can discuss more tomorrow then. Thank you.
No worries.
So we are arriving at our workflow, which we've received some more information about in terms of faxes being received or not in the clinic. Hilda, I see we have 15 minutes left. Do you think it's worth starting this demo, or should we hold it off till tomorrow when we have more of the gang back together? Because this would be our last chunk of content for this presentation for design.
And there's no other follow-up questions after?
Let me hop over. We have forms, so talking about forms for Form Pass, and then some general clinic questions as well.
Maybe we'll ask the general questions since we do have 15 minutes. Let's get
sounds good.
some use of our time.
Okay, so Joan, again, you can defer or wait till we can have Alex and maybe Catherine back. We had brought this up at a previous presentation. Would the PCRNs like case conference to be an appointment type in Cerner? We did get sidetracked, so we didn't actually get our answer. But off the top of your head, what are your thoughts on this?
Are case conferences the same as ICCs?
What does ICC stand for again?
What is an ICC? Interdisciplinary Care Conference. They typically happen before discharge, usually between acute and community.
Yeah.
Yeah. So are these case conferences the same?
Cynthia, go ahead.
It can be. But I just wanted to make note, because I remember now talking about this, that we've only created the doctors as resources. And I do believe that you said that sometimes you include the doctors in. So do you need to block off time? I think that's the key, is if we create an appointment type for case conferences, we want to make sure that, it'll be the doctors that we're blocking off because they're the only ones that are in Cerner. Is that true?
Yeah, they're the only providers. No worries. The doctors typically don't join ICCs, so I don't think that this will need to be an appointment type. But again, let's defer until we've got Alex, Catherine, Stephen as well input.
Okay, sounds good. And that was my second question, was around the provider. In the long-term care setting, Joan, typically the palliative providers wouldn't go to an annual case conference, would they? No, it would be the MRP and maybe yourself and interdisciplinary. Okay, great. And Joan, again, have you ever seen Lara, your nurse educator, do anything akin to registration or scheduling? Appointment scheduling?
Not in her current role. Not in her current role. There was a time where she was covering a hybrid PCRN PSM role, but now that she's firmly in her educator role, she hasn't done any cross coverage. So I don't think she would need to.
Okay. Good.
But again, I'd want consensus on that.
Of course. At least we've got the context. And this one more appropriate to Catherine, so clinic billing. So I wouldn't expect you to know that. And Joan, you might know this, you might not. So this is a scenario question I had. So say a client is being seen in the PSM clinic and they become homebound due to their symptoms, and they're not currently accessing home health nursing, but they kind of have a relationship with the clinic and the palliative providers. And say they want continued care, but now in the capacity of home visiting, would they still need to start home health nursing services and get that home health nurse to PCRN report in order to get an appointment booked?
Yes, I believe so. I think they have to be in the home health nursing system first, and then they can access a provider.
Okay. Yeah, okay, makes sense. Okay. Any questions from you, Joan or Sabrina, or anyone else?
No, so far, good. It's all good.
Okay, great.
Yeah.
Excellent. So we will see everyone again tomorrow at 2:00 in the afternoon. And just out of interest, also on December 1st, which is coming up this Friday, we'll see a design session. So similar concept, specific to scheduling. So that one's a little shorter, 9 a.m. to 10 a.m. And you'll see most of the same faces at that session. In terms of validation, which Vince briefly covered in his intro slides, that one we're looking to be booked in January. So a little bit of time before we get to that date. And those are our next steps. All right. Hilda, or anyone else on the team, anything I've missed for this afternoon?
Nothing that I could think of.
Okay, excellent. Well, we got an extra 10 minutes, so that's a new for us. So we're glad to see that. So we will see everyone again tomorrow afternoon at 2 p.m. Thank you so much.
Thank you, everyone. Bye for now.
Thank you.
Thanks,
Thank
everyone.
you.
Bye.